Hi, I'm Rami Komrokji. I'm Vice Chair of Malignant Hematology Department at Moffitt Cancer Center. At ASH this year, we are presenting the impact of genomic landscape and mutational burden on responses in the COMMAND study. So as you know, Luspatercept was originally approved for patients with lower risk MDS that are transfusion dependent with ring sideroblasts. However, recently the COMMAND study was presented both at ASCO and EHA, and will actually be presented again, the final analysis at ASH as well, looking at moving Luspatercept upfront in treating MDS patients. So in the COMMAND study, patients were randomized between Luspatercept and erythroid-stimulating agents. Those were lower risk MDS patients that were needing some blood transfusion. And the primary endpoint was transfusion independence for 12 weeks with a hemoglobin increase of 1.5 grams, which is a robust endpoint. And obviously, the Luspatercept showed doubling of the response, 60% versus 30%, and doubling of the duration. And based on that, the FDA recently gave the approval for using Luspatercept as frontline therapy. So in our abstract, we did analysis from the COMMAND study looking at the impact of the genomic landscape. So there were mutation data available almost for 350 patients on the study in both arms. And I think the key findings to summarize, first is that we noted that the Luspatercept showed broad activity across multiple MDS-associated mutations. And some of those mutations are known to have low response rate to other treatments, such, for example, ASXL1, that have low response rate to azacitidine. So we saw the activity of Luspatercept in favor of Luspatercept compared to ESA in all those mutations, probably with the exception of the CBL or CBL mutation. And we also looked at that particularly in the ring sideroblast negative group, because that's the group that, the efficacy of Luspatercept and erythropoietin was almost the same, but we see still that, the activity of Luspatercept was favorable among every subtype. Then we also looked at the mutation burden, like the number of mutations and the response. And interestingly, in patients that had 1, 2, or 3 mutations, Luspatercept outperformed erythroid-stimulating agents in a statistically significant way. In patients that have 4 or more mutations, obviously the activity is low for both of the treatments. But in patients with 1, 2, or 3 mutations, the responses were better. We also noted that the patients that, are RS negative that received erythropoietin had less mutation burden at the baseline. So in the COMMAND study, there were 50 patients almost in each arm that were RS negative. And in the RS negative, the Luspa and erythropoietin had the same efficacy, while in the RS positive, Luspa had double the response. But when you look at the population of the RS negative, the mutation burden was more in patients that got Luspatercept. Or maybe explaining some of the differences why the efficacy was similar, not that superior. So the take-home message, obviously, Luspatercept is moving up front for management. Luspatercept showed activity across all subtypes, regardless of the mutations. Luspatercept was more effective in patients that had 1, 2, or 3 mutation burden. And it seems that there was some imbalance at the baseline with less mutations in patients that got erythroid-stimulating agents. We also looked at the responses based on restaging the patients by the ISPSS-M, the new risk model, and we saw the analysis favoring Luspatercept over ESA across all the subtypes of the IPSS-M as well.